Thank you for your interest in Maxwell Biomedical. Maxwell Biomedical is a startup company based in San Diego, California, USA. We are engaged in developing a non-ablative, AF-specific device-based treatment for atrial fibrillation that actively monitors the heart rhythm to detect AF and then imperceptibly restores and maintains sinus rhythm to slow or stop disease progression. The idea of treating AF with a device-based solution is not a new concept. Pacemakers were originally developed to treat patients with slow heart rhythms, also called bradycardias, with less than 1% being prescribed for fast heart rhythms like atrial fibrillation. Early pacemaker models were large, bulky external devices that successfully maintained the patient's heart rate, but were impractical for everyday use. Technology rapidly evolved to permanent implantation of one or two wired leads located either in the right atrium, the right ventricle, or both chambers. The leads were then connected to a small device containing electronics and a battery that was placed under the skin, usually in the pectoral region. Initial experience with pacemaker implantation revealed that some patients with bradycardia were also developing atrial fibrillation, a clinical syndrome called sinus node disease. It was then later discovered that ventricular dyssynchrony arising from pacing the right ventricle contributed to the development of atrial fibrillation. The MOST trial demonstrated that the addition of atrial sensing or pacing to maintain atrial ventricular synchrony reduced the number of AF events in patients with sinus node disease. Based on data from multiple sources, including the MOST trial, several novel, complex atrial pacing algorithms were introduced to suppress AF. These included pacing from two sites, overdrive pacing at a rate slightly faster than the natural rate, pacing in response to a premature atrial beat, and preservation of natural ventricular conduction. Trial results using these strategies were disappointing, with large-scale trials confirming minimal or no beneficial response in reducing the number of AF events. External cardioversion has remained the gold standard for restoring sinus rhythm in patients with prolonged episodes of AF. Administered as an outpatient procedure, therapy is often delayed by 3 to 4 weeks due to scheduling constraints and need for anticoagulation. Patients perceive the energy levels required to cardiovert AF as painful, requiring sedation prior to shock delivery. Treatment typically starts with a 100-joule shock, and the energy is ramped up if unsuccessful. Most patients require 2 shocks to successfully restore sinus rhythm. With 50% of patients recurring within 3 to 6 months and a cost of $1,500 per procedure, serial cardioversion is impractical as a long-term therapy. In the late 1990s, Medtronic and In Control developed devices that delivered either automatic or patient-initiated internal cardioversion therapy. Both were effective at significantly reduced energy levels when compared to ventricular defibrillation. Long-term studies demonstrated a trend towards a reduction in the frequency of AF episodes with cardioversion success. Anti-tachycardia pacing, or ATP, had demonstrated success in painlessly terminating stable ventricular tachycardias and reduced the incidence of shock delivery. Attempts to reproduce the same result in AF were largely unsuccessful. With increasing levels of pain, the effectiveness of device-based AF therapy improved. As the patient's perception of pain decreased, so too did the level of effectiveness of device-based therapy. For most patients, the pain level associated with successful therapy was intolerable, and many patients requested shock therapy be disabled. Coupled with a lack of ATP success, adoption of device-based therapy for AF has been limited. The current state of device-based therapy for AF is largely unchanged, focused on reducing or preventing the development of AF instead of restoring sinus rhythm when AF occurs. Current pacemaker guidelines published by the American Heart Association and more recently by the European Society of Cardiology are consistent in not recommending the use of device-based therapy for AF. Both organizations cite a lack of consistent data and benefit in the absence of bradycardia. So what makes the Maxwell solution different from what has been tested in the past? The answer is that the insights gained from the past inform the discovery of a new methodology rooted in the underlying biophysics of human fibrillatory conduction, combined with the development of a new technology with a singular focus on AF. The Maxwell solution is called spatial resynchronization therapy, or SRT, which senses and paces from multiple electrodes spatially distributed across the outside surface of the left atrium to resynchronize the chaotic wavefronts of AF and restore sinus rhythm. In summary, device-based therapies have been tried in the past with limited success. Armed with insight from earlier device-based therapy attempts and technological advances, Maxwell is developing an AF-specific, non-ablative, non-pharmacologic device-based treatment option. Our SRT system addresses the need to actively manage AF, deliver imperceptible therapy, continuously restore sinus rhythm, and provide daily monitoring. Thank you.